Now it's my privilege to introduce my co-chair, Professor Roseman. He will actually, there was a last-minute change on the program. Dan Attar, which he is our Vice President of ESC, had a problem in his flight connections, so he could not make it. But he organized with Joseph for him to give his presentation on the modern treatment of atrial fibrillation from guidelines to implementation in clinical practice. So thank you very much, Joseph, for filling in at the last minute.
So thank you, Fausto. I actually got the slide presentation during lunchtime, and I went over the presentations, and I can tell you that it's not an easy task to, well, with the digital revolution, you can get the slides, but I'm not sure that you can actually get what was the thinking behind the slides. And I'll try to do my best to try to convey to you the main messages that Professor Attar was going to make in his presentation. So the title is Modern Treatment of Atrial Fibrillation from Guidelines to Implementations in Clinical Practice. So that's a real challenge in general. To write the guidelines, it's not very easy, but to implement them, I think it's much, much, much more difficult. And we'll see what was the time course that was taken by the ESC in order to help in the implementation of the guidelines in atrial fibrillation. I think that's the main thing that Professor Attar was going to make. This is Oslo University Hospital. I have never been there. And these are the disclosures of Professor Attar. And I think it's important to know that he was very much involved in the issue of atrial fibrillation. And you can see that he was a co-author of the 2010 and 2012 ESC guidelines on atrial fibrillation. STEMI guidelines are not that relevant here, but he was also in the steering committee of many of the most recent and important randomized trials about anticoagulant treatment in atrial fibrillation. So that's relevant for his presentation. Definitely, he has a lot of information both on what was published and both on what was happening behind the scenes. This is actually, as a background, some data that Professor Attar took from a study of Moti Chaim from Israel that describes the prevalence of the prevalence of atrial fibrillation and the change in prevalence of atrial fibrillation in males and in females at different ages. And you can see what we really know, that when you approach to an age above 80, we are talking about between 10 and 15% prevalence of atrial fibrillation, so definitely something that requires attention. And that's something else that is from Israel, and it's quite depressing. We see that the mean TTR in this prospective cohort was only 42%. As you can see here, only 17.4 patients were well controlled, when controlled is defined beyond 65%. And with this background, we start with the initial guidelines on 2010 on the management of atrial fibrillation. This is a task force of the ESC. And I think what Professor Attar wanted to mention is that these guidelines were written, a lot of physicians were involved. And as you can see here, the task force members, there were 25 task force members. There were 17 members of the ESC Committee for Practice Guideline, and there were also 26 reviewers. So in general, about 80 physicians were involved in the writing of these guidelines. These are slides that I think we are all familiar with about the class recommendation, 1, 2, 2A, 2B, and 3. So I'm not going to go over that. And the level of evidence that is also familiar to all of us. Interestingly, in these 2010 guidelines, there were 210 recommendations. And you can see here the split between the class recommendation, 40% class 1, and the other in the different other percentages. But something that is not typical just for atrial fibrillation, we see that in more than 50% of the recommendations, the level of evidence will see, which means an expert consensus. And that's something that we see in many other guidelines as well. In 2012, there was, 2 years later, there was a focus update on the ESC guidelines for the management of atrial fibrillation. And here the focus guidelines involved only eight writers, so much less than the guidelines themselves. And the reason for the focus the focus update concentrated on anticoagulation risk stratification, on the use of novel oral anticoagulants, and I'm not going to discuss the rest of the things that were appearing in the focus guideline because they are not related to the issue of anticoagulation. One of the new things that appear in the focus guideline is the opportunistic screening, and it got a recommendation of level 1B, and it says opportunistic screening for atrial fibrillation in patients above 65 years of age using pulse taking followed by an ECG is recommended to allow timely detection of atrial fibrillation. I think even though it looks not very sophisticated, I think it's a very important recommendation because I'm not sure that all our physicians, family practitioners, or cardiologists take in general the pulse of the patient, and that can have many implications if you detect atrial fibrillation in an asymptomatic patient above 65, and we'll see why above 65. This is the logical sequence of AF management, and we'll focus on the issue of anticoagulation. And the first step is assess the thromboembolic risk and then decide about oral anticoagulant, aspirin, or none. So we'll move forward from that. And here we can see, I think, the best meta-analysis on the 4 pivotal trials on the different agents, different NOACs. And what we can see here, that's a publication by Ruff in Lancet 2014. And what we can see is that regarding the efficacy, there is, in general, in this meta-analysis, approximately 20% reduction of the risk of stroke and systemic embolism. And interestingly, there is also about 14% reduction in the risk of major bleeding. But you can see here that as far as major bleeding is concerned, it's not the same in all trials. There are some variation among trials. We have to be very careful comparing one trial to another because there are variation in patient population and many other things, but it doesn't look like in the first part of the slide that the trend is the same in all of them. CHAD score that we are all familiar with was the method to assess the score, the risk of the score for the stroke rate. And in the focus guidelines, there was a change from the CHAD score to the CHAD-VAS score, reflecting the increased importance of age, female sex, and vascular disease in the assessment of the risk of patient. And we can see here that after this presentation, there were additional manuscripts that actually validated the CHAD-VAS score as the better risk score to assess the risk of stroke in atrial fibrillation. And in fact, this CHAD-VAS score was also adopted by the American guidelines. So CHAD-VAS score is here to stay. And we see here the estimated stroke rate with the various CHAD-VAS score. And we can see that when the level is 0, then the risk is 0.78, which is kind of borderline regarding a decision whether to start anticoagulant treatment. But with 1 and above, with a risk of 2 and much more than 2, then the balance in favor of anticoagulants is there. And that is what's leading to the scheme of the recommendation of the ESC about how to treat patients. And you can see here on the left of me, right of you, that only those patients that are less than 65 years of age, including female, with no additional risk factors, in them no antithrombotic therapy is recommended based on this focus guideline, focus update. In all other CHAD-VAS score, there is a recommendation of anticoagulation, and the line that is filled reflects the fact that there is a preference for NOAC over VKA antagonist in these recommendations. So to summarize the conclusions from the ESC 212 guidelines update is atrial fibrillation update emphasizes the need for stroke risk assessment in atrial fibrillation. The focus is on identification of truly low-risk patients. All others, all anticoagulation recommended. Aspirin is no longer recommended. All anticoagulation can be either with warfarin or with NOACs, but the 2012 ESC guidelines encourages the use of NOACs as the preferred option in suitable patients after thorough identification of the potential contraindication. So that's where we stood at 2012. And actually, despite these guidelines, there were lots of barriers among physicians and cardiologists as well, what to do in different situations, how to handle NOACs in these different situations, and that actually led to a less implementation of this recommendation of NOACs. And here comes the EHRA practical guideline on the use of new oral anticoagulants in patients with non-valvular atrial fibrillation. And the motto is that the 2010 and the 2012 do not detail the NOACs in specific clinical situations that we encounter very frequently. And there are multiple physician tools supplied with each drug, and they may be confusing. And the EHRA has now produced a practical guide to supplement the AF guidelines. I must say that it's not evidence-based, it's mostly consensus, but it's very logical. And the focus is on typical situations, common situations, challenges that we are faced with when we are treating patients with atrial fibrillation, and we'll start with renal dysfunction, which is quite common. So for that, we need to understand a little bit about the pharmacology of the different NOACs. And what we can see here is, in this slide, is the estimation of the half-life and the variation of half-life of the various anticoagulants with the decreasing renal function, with decreasing rows. And we can see that no surprise that with dabigatran the half-life is increasing, because the main mode of elimination of dabigatran is the renal elimination. And with apixaban and rivaroxaban, the changes are not as dramatic as with dabigatran. What we can see here in parentheses is also the area under the curve of the plasma concentration. What we can see here with apixaban, and that there is, despite the fact that there is not that much variation in the half-life, there is still an increase in the area under the curve, and the area under the curve is associated with the blood level, and we can see an increase from 16% to 44% as compared to normal individuals with declining renal function with apixaban, and slightly more increase with rivaroxaban, 44% up till 64%. So that's the impact of renal dysfunction. And based on this variation in half-life and the area under the curve, these are the practical recommendations about what to do. And actually, in fact, if you have a creatinine clearance of between 15 and 30, or even if it's with 30 to 49, and there are some other interacting factors such as verapamil, the recommendation is not to give, the European recommendation is not to give dabigatran. With apixaban and rivaroxaban, between 15 and 29, there is actually a recommendation to reduce the dose, and it also depends on other parameters related to the patient. I'm not talking about the American recommendation to use a dose of 75 BID, which was determined just based on pharmacokinetic and not based on clinical information. The second issue is the need for surgery that occur, unfortunately, not very rarely. And here we can see when to stop NOAC before planned surgical intervention. And there is a table that I think that it's very difficult to learn the numbers exactly, but I think it's all common sense. And what we can see here, that with decreasing renal function with the dabigatran, we see that there is increase in the time delay between last dose and surgery in low-risk patients from 24 to 48 hours, and in high-risk for bleeding surgical patients is from 48 to 96 hours. While when compared to apixaban and rivaroxaban, we can see that renal dysfunction does not change that much the time delay between last dose, and we can see that in the low risk is 24 hours, both for rivaroxaban and apixaban, and in the high risk doesn't change with renal function, but increased time delay when it's high-risk surgery. And when to restart NOAC after planned surgery. So if the procedure is with immediate and complete hemostasis, then the recommendation is to resume the NOAC 6 to 8 hours after surgery. If the procedure is associated with immobilization, then there is a recommendation that I'm not sure that everyone is going to agree on that, is to use reduced dose of low molecular weight heparin after surgery if hemostasis is achieved. And in general, the recommendation is to restart NOAC 48 to 72 hours after surgery, only upon completion of hemostasis. I'm not going to go over the classification of surgical intervention according to the bleeding risk. And regarding concomitant coronary heart disease and acute coronary syndrome, something that we are encountered very frequently in our daily practice. What we have is, the best data that we have is actually post-hoc analysis from RELY about use of all anticoagulant, both warfarin and the 2 doses of the Bigatran, together with a single and dual antiplatelet agent. And what we can see here, this is with all anticoagulants, this is without antiplatelet. With a single antiplatelet, the risk of bleeding is increasing, and with dual antiplatelet, it's increasing much more. And the same trend is with 150 milligrams of the Bigatran, and same trend also with 110 milligrams of the Bigatran. But what we can see that the advantage of the Bigatran over the warfarin, especially in the 150, is that it's always this value is lower than that, this value is lower than that. So definitely antiplatelet therapy increased the risk of bleeding with both warfarin and the Bigatran, but the advantage of the Bigatran over warfarin remains even after the use of antiplatelet therapy. And both RELY, ROCKET, and Aristotle demonstrates very similar trends, although in Aristotle and in ROCKET there is not so much information about dual antiplatelet therapy. Some additional information is regarding the role of oral anticoagulants, mainly the novel oral anticoagulants, for treatment of patients with acute coronary syndrome without atrial fibrillation. And these are a couple of studies that were examining this issue. And that's a meta-analysis of these trials that show that when you use a single antiplatelet agent and when you judge the MACE, all-cause death, MI, and stroke, you actually get a benefit, 30% reduction in MACE when you add NOACs to a single antiplatelet agent. But together with this better effect on better efficacy, you increase the risk of bleeding by 80%. So that's with a single antiplatelet agent, which is not very common in our daily practice. When you move to what we do usually in patients with acute coronary syndrome with dual antiplatelet therapy, then the benefit as far as the MACE is decreasing only 13%, but there is a very significant increase, 134% in the risk of bleeding. So in general, even though rivaroxaban at low dose was approved, I think, by the EMEA for additional treatment for patients with dual antiplatelet, in Israel it's not something that we are doing. I'll go to the comments. Caution, busy slide is ahead. And the busy slide ahead reflects the fact that we really don't know what to do in patients with coronary artery disease, with ACS, with stable coronary artery disease that have also atrial fibrillation, what to do as far as dual therapy, triple therapy, and this is the busy slide. But despite the fact that it's a busy slide, I think we should go to step 1. And step 1 is assessing of the risk of stroke based on CHADS-1, based on CHADS-VASc1, and greater than 2. The second step is assessing of the bleeding risk based on has bled. And then we're talking about what the procedure that is done, whether it's stable coronary artery disease and ACS. And with all this information, then you get this cookbook that tells you when to use oral anticoagulants, triple therapy, when to use oral anticoagulants with double therapy, what's the length of triple therapy, what's the length of dual therapy, And once again, I don't think that anyone can remember all this, but basically you have to make your decision whether the risk of stent thrombosis is very high and the risk of stroke is low. Maybe you can even settle with just dual antiplatelet therapy without oral anticoagulant. So really it's, once again, not evidence-based, common judgment, and that's what we do very often in medicine. And that's a simpler version of the table, reflects only the recommendations in ACS. So I'm coming to the last presentation, to the last slide of the conclusion. Risk scoring with CHA2DS2-VASc is the recommended instrument to estimate AF patients' risk for embolic stroke. Treatment with NOAC is the preferred choice rather than warfarin in non-valvular atrial fibrillation. And NOAC treatment is easier than warfarin. Nevertheless, it requires a thorough follow-up as well as high degree of care and, I would say, understanding and knowledge of the pathophysiology of the pharmacokinetic and interaction. And the approach that was taken last year in the European Society of Cardiology, so the last 2 years, number of useful documents have been released, position papers, practice guidelines, which provide practical advice for a number of issues, e.g. dose reduction in renal failure, drug-drug interactions, need for antiplatelet therapy, and many more clinical scenarios. Thank you very much.